Can you hear me now better? Yeah, okay. So thank you for coming out on a Saturday afternoon, and thank you to my mentor, Dr. Desai sir, for setting the ground for which I can build on. So you have already talked about the importance of history taking, and my job would be to help shape all that history into some patterns which we can recognize and give a diagnosis. So thank you to the Bombay Psychiatric Society for giving me this opportunity to talk. And thank you, Naya ma'am, for introducing me as well. So to move to the next slide, the goal for my talk is going to be to understand the pathophysiology, symptoms, and signs of various neurodegenerative disorders. What is not in the scope of this talk is to go in depth into each and every disease, because we have a very limited time that I can talk on, and I want to cover as many neurodegenerative diseases as possible. So what caveat I'm giving here is I may not be able to go into the deeper aspects of each disease, but I'm going to touch on each one of them. So the objectives are going to be to talk about Alzheimer's, vascular dementias, NPH, then alpha-synucleinopathies, tauopathies, and TDP-43. So what I'm not talking about here is reversible causes of dementia or those which can be corrected. So why do you need to pay attention to this talk today? The most important part is that we can better anticipate the clinical outcome from the story that's going to be painted, and also to give better holistic treatment to all the patients that we'll be diagnosing. So when I was training at Calgary, the way that we would approach patients in the cognitive clinic would be along 3 axes. So axis 1 is the functional status. So as sir rightly pointed out, if a person came to the clinic with changes in their personality, with changes in their memory and thinking, then we would assess if they had any changes in their quality of life. If they did have, and the neuropsych testing scores were normal, then the patient would be labeled with the diagnosis of subjective cognitive decline. If there was a change in their quality of life, and there was a decline in their neuropsych testing with age-matched peers, then the diagnosis would be given as mild cognitive impairment. And if there was a functional change where a person was no longer able to do activities of daily living independently, which is a change from their baseline, and that's when we use the diagnosis of dementia or a major neurocognitive disorder. The second axis on which we kind of understood our patients was to label them with what kind of disorder they had and what parts of the brain were being involved. Whether it was just a pure amnestic type, whether it was an amnestic plus syndrome, whether it was a behavioral syndrome or a dysexecutive syndrome, or whether there was language predominantly involved. And the third one, which was the most important one, was what's the etiology driving these changes. So the ultimate outcome would be that they have cognitive changes, they have personality changes, they have thinking pattern changes, but what's the etiology that's driving these changes? So the most common one is Alzheimer's, and the second common one would be vascular, and a combination of both of them, or mixed. So I'll be reviewing all these diseases that I've laid out here, and I want to start with this image. So this image is a self-portrait by William Uthermohlen, and this is in a museum in London, the GV Art Gallery. This is his self-portrait at the end of his journey of Alzheimer's disease. So this is in the year 2000. And if we go an year back, this is how his visuospatial dysfunction was. So it's been progressing. This is an year back, so this is 1998. And then you have 1997 and 1996, and this was his self-portrait in 1967. So why am I showing you this? I'm showing you this to highlight 2 important points. Number 1, that as most neurodegenerative diseases progress, they all end up with global cerebral dysfunction. So it's very difficult to tell what's the underlying neurodegenerative pattern once a person, especially in the Indian context, comes to you at an incontinent stage or has become bedridden. So now to give a label of what's the potential diagnosis is a very tricky task to do. And the second thing is the importance of neuropsychological testing or neuropsych testing. So neuropsych testing done at this stage of a person's journey is not going to yield any dividends. So if a person comes to you at an earlier stage, say this stage, it's at this stage that doing neuropsych testing is of value, because then you can give a diagnosis of what possible etiology is driving these changes, and what would be the likely prognosis, and what would be the best strategy to manage these symptoms. So I would highly encourage and endorse neuropsych testing at earlier stages and not at later stages of the disease process. So coming to hypothetical cases that I've set up to help map different aspects of the diseases that I'll be talking about. So Mrs. M is a 75-year-old retired school teacher. So you can see that the age 75, I would call it as the older age group. Politically may not be correct, but anything older than 65 would be something that would be considered as on the older side of things, who is brought in by her daughter for gradually worsening forgetfulness over the past 1 to 2 years. So we can see that there's a gradual progression across 1 to 2 years, and it's not a subacute but a chronic course. The second point to highlight is I have deliberately kept it as a gender being female, because females have a twice likely higher odds and risk to progress to dementia than men have. So with all these hints, you might be starting to form an opinion of what this case is. She often misplaces household items, repeats questions, and forgets recent conversations. Through long-term memories, though long-term memories remain relatively intact. So to help understand this sentence, we need to understand how the hippocampus works. So the hippocampus is a memory encoding organ. The work that it is essentially doing is it's tagging your episodic memory. So for example, the memory that we are making right now, the episode of me talking, the hippocampus is going to tag it for relevance. So if I say something of relevance, your hippocampus will tag it. So it keeps on accumulating these tags throughout the day, and when we sleep, in our NREM sleep, all these tags get pulled out, and in our sleep spindles, the memory gets converted from short term to long term. So that process of consolidation takes place in sleep. But it's the hippocampus, which is the main organ, which is going to try and encode these memories. So if a neurodegenerative process is affecting the hippocampus, what will come with it is this classic scenario where you have difficulty encoding what are the recent things you have done. So you tend to forget that you have had a conversation, and you tend to forget what were the recent events that you have had. So loss in episodic memory is what I'm trying to talk about here. Then her family notes that she has become increasingly withdrawn and occasionally struggles to manage finances and follow similar recipes. So what we can understand or interpret from this sentence is that along with memory dysfunction, there can be executive dysfunction as well. And both of these go hand in hand. So for executive functioning to work, you need to have good working memory, and you need to have good episodic memory as well. For example, in this talk, whatever you have been listening to so far, if your episodic memory was not good, you wouldn't be able to refer back to the initial parts of the conversation to understand what the current context is. So when a person starts having difficulty following along a conversation for a longer time, they naturally tend to get more indrawn, and that can also drive depression. So it's a chicken and the egg phenomenon. Whether depression is a risk factor for Alzheimer's, yes, but Alzheimer's itself can also drive the onset of depression. So it's very difficult to tease this apart, but especially knowing that people who have difficulties in coding their memories can tend to be socially withdrawn, and social isolation is not good for them. So we need to balance that out. Another symptom or negative history would be no history of a prior stroke. So vascular dementia or vascular cognitive impairment is the second most common cause. So whenever you're taking a history, having a negative history of ruling out any prior strokes is very important. Head injury. Head injury is one of the biggest risk factors for progression to Alzheimer's disease. So ensuring that in your history taking, you have asked for ancillary history of any past head injuries, any concussions, any loss of consciousness is very important. And this is also a risk factor which can be mitigated. So if you're a sports person, or if you're vulnerable and have an occupation that predisposes you to head injuries, you should take more precautions so that you don't progress on to have neurodegenerative diseases like Alzheimer's. And also uncorrected hearing or vision loss. I've added this sentence in to prime you that whenever a person at this age group comes in, hearing loss is a very important risk factor for progression to Alzheimer's and dementia. So correcting them is a very important, simple thing that you can do by referring them to an audiometrist and an optometrist so their hearing and vision can be improved. So this lady has hypertension and type 2 diabetes for 15 years, both moderately controlled. So hypertension and type 2 diabetes are again risk factors which can predict Alzheimer's in the future. The pathomechanistic measures could be vascular driven and could be the poor impaired lymphatic clearances, but that we'll discuss at a later stage. But knowing that hypertension and diabetes are a risk factor will help you put the whole picture. So when a person comes to a cognitive clinic for memory complaints and is being given a potential diagnosis of Alzheimer's, addressing and making sure that their HbA1c levels are done, correcting them, ensuring that the blood pressure are very well within normal limits is a very important thing to be done. On examination, she is oriented to person but not to the date or place and would frequently look towards her daughter for answers, and with impaired episodic memory and preserved language and motor function. So orientation to person but not to date, place is something which is very important in Alzheimer's. As Sir taught us, the default mode network, the posterior cingulate gyrus is a very important part of the default mode network, which helps regulate orientation to time, place, and person. So the sequence in which the posterior cingulate cortex, the default mode network symptoms arise is loss of context. So Alzheimer's patients typically start having difficulty understanding what's the social context in which they are setting into, followed by a loss of orientation to time, what time of the month or year or date it is, and then later on time of the day. What place is this? What's the orientation to place? And then last thing to go would be orientation to person, how different people around me relate to me. So that comes from the posterior cingulate cortex. And typically on PET imaging scans, that is one of the first areas to go. Then another point I wanted to highlight here was the head turning sign. So in the clinic, whenever you ask the person, what's your complaint? And they look at the caretaker. So that head turning sign is a very important sign clinically to tell us that this could be going more towards an Alzheimer's diagnosis. So neuropsychology testing, I thought I'll add this in our context, because when I was doing my training, we didn't focus much on the neuropsych aspect of things. But having come back from Canada, I think this is a very important topic to deal with. So there is impaired, delayed recall and recognition. So on the MOCA, when you do the 5-point recall, that scores are typically what are declining. And if you give them a chance to recognize those 5 words in, say, another scrambled list of 10 words, then that is also something that is lost and they're unable to recognize. So there is an increased false positive rate in recognition. So that's, for example, one of the 5 words was flower, and in the scrambled words I gave them garden as well. So they would tend to think that the garden was a word which I had given in the initial list. So that is something called confabulation, where they believe that this was the right thing, and they tend to have false positives in recognition. So paired associate learning deficits in neuropsych terms, we can give them, say, 5 different faces or 10 different faces and give them names to remember that, okay, this face belongs to this name. Or you can give them word combinations, say an apple and a tree, or a pastry and strawberry. And when you ask them to recollect these paired associate learnings, that is also typically impaired in patients of Alzheimer's. Lower primacy portion than recency portion. What this refers to is, suppose we give them a list of 10 random words to remember, they will tend to remember the last part of the 10-word list. Why that happens is because we have a working memory span which typically goes around 4 to 7 digits. So in a list of 10 random words, they'll tend to remember the last 2 or 3 words and forget the first initial part of the word list. So that is what is meant by lower primacy portion than recency. Then semantic word fluency deficits versus preserved phonemic word fluency. This is a very important thing that you can do in the clinic. You can ask them to come up with words starting with F or F, that would be phonological fluency. Or you can ask them to give categorical fluency, like, say, give list of all the animals that you can name or all the fruits and vegetables. So in Alzheimer's, typically, it is the semantic word fluency that is lost. So they tend to have reduced amount of knowledge, so they are not able to come up with the list of, say, animals. That would be less than, say, 10 in a minute. Whereas they will have enough ability to produce more words with, say, the alphabet S. So that is an important thing to differentiate with vascular dementia, which I'll talk about. And there's no impairment on the digit span task. Alzheimer's patients are generally taxing their working memory. So it's the working memory which is relied on heavily for the digit span task. So you won't see much changes in that aspect. So this is the MOCA, which can take about 10 to 15 minutes to be done in the clinic. And a lot of data points can be got on this simple screening test. The caveats in the Indian context would be that MOCA is highly sensitive for screening patients at a mild cognitive impairment stage. And the MMSE, which is a test which can be done, and the Hindi version of it is called as the Hindi mini mental state examination. So both these tests, the MMS is more sensitive to predict dementia, whereas the MOCAS test is more sensitive to predicting mild cognitive impairment. So this is the pathophysiologic slide, which is showing you what Alzheimer's looks like on gross pathology. And what you can see here and appreciate is the large roomy ventricles. And this shows generalized cerebral atrophy, as well as the very big temporal fissures here. And they show that there's a lot of hippocampal atrophy in comparison to the normal one. So this is how Alzheimer's typically presents with, and this would be called as the amnestic variant of Alzheimer's disease. So what are the other rarer phenotypes of Alzheimer's that we can talk about? So one is the early onset variant of AD, and you would label it as early onset when the symptoms arise before the age of 65 years. They are often more rapid in onset and decline, so there are a few stories that I can tell you. One of them was, I had the opportunity of seeing a person who presented at the age of 58 years. And he was very young, there was very rapid onset and decline across few months, 6 months to 7 months. And we had done his CSF biomarkers, which are strongly positive for an amyloid and tau pathology. And the problem is more caregiver burden because they're younger onset, so they still have family members who are dependent on them. Like the patient that I was trying to tell you about, the children had not even graduated school yet. So having an earning member of their family member affected by this disease really takes a toll on caregiver burden. Another thing that happens in early onset AD is that there are non-memory deficits which predominate. For example, there are language changes or visual, spatial, and executive dysfunction in comparison to the later onset of Alzheimer's disease. So genetic forms generally fall under the umbrella of early onset AD, and those would be APP mutations, presenilin 1 and presenilin 2. So talking about another rare variant of AD, logopenic variant of primary progressive aphasia. In this illness, the pathophysiology is an amyloid and tau pathology, and hence I've kept it under the term of Alzheimer's disease. There are frequent word finding difficulties, and there are repetition deficits. So the two negative symptoms to remember here is that repetition is impaired and there is word finding difficulties. So the volume of speech that they have is generally reduced. There is comprehension for single word which is preserved. So if you ask them to say, what is this? They would say it's a watch, and they wouldn't be able to tell you what the use of that watch is to tell time. And they will also have grammar and articulation which remains intact, which will help differentiate it from other types of primary progressive aphasia. Reading and writing would also be slow and would show phonological errors. What are phonological errors? Suppose I ask them to write apple. They may write bapple. So that would be an example of a phonological error. And most of these cases, as I said, have an AD pathology at time of autopsy. Another rare variant is the posterior cortical atrophy, or PCA, and we can appreciate clearly the pattern of atrophy that involves both the occipital lobe and parietal lobes. So they have predominant visual, spatial, and perceptual deficits. So one case that I can narrate is that there was a 59-year-old gentleman who came with presentation of running his car over a divider. So why did he run over a divider which was clearly obvious? It wasn't an oncoming traffic problem. So that was because of visual, spatial, and perceptual deficits. So he was not able to judge the distance between the divider and his car. He turtled his car, and since then onwards, they started evaluating him, and they found out that he's having a rare disease of PCA. I will digress a little and complete that case because it has some emotional significance to me. And that was one of the first cases where I saw and I realized the difference in the healthcare structure of Canada and India. Once he had these symptoms diagnosed, he underwent a CSF study for AD biomarkers, and it was proven to him that this is an Alzheimer's pathology driving his change. And because he had intact reasoning, so he was very good at thinking about his long-term future, and execution function was intact. He chose to undergo medically assisted intervention in dying, or MAID or MAID. So that was one of the first patients I saw after a diagnosis of a neurodegenerative disease which was proven by CSF AD biomarkers. He discussed it with his family members and decided he doesn't want to suffer through this entire process. He underwent medical assistance in dying, and I was there at the time of his autopsy to see how the brain looked in real time with the occipital lobes being atrophied, as well as the amyloid and tau pathology which was there. And I also remember that there was synucleopathic changes in that brain, talking about how even though we say that this is an Alzheimer's pathology, there still is a mixed pathology going on under the seal. So there was some synucleinopathy in him as well. So that's a very rare variant of Alzheimer's disease. And this might be relevant to us, majority in psychiatrists in the crowd, where dysexecutive or behavioral variant of AD. So they would present predominantly with executive dysfunction, behavioral changes, personality changes, and they often mimic behavioral variant of FTD. The problem is the prognosis would be different. Typically, a person diagnosed with Alzheimer's disease pathology, the prognosis would be anywhere between 8 to 14 years, whereas that with behavioral variant FTD would be anywhere between 7 to 9 years. So there's a change in prognosis to be expected, as well as the caregiver burden are different because of the higher behavioral stress in FTD. So how to tease apart executive and behavioral variant? Most of the patients, this is a very rare presentation actually, and those patients were diagnosed with behavioral variant FTDs when they underwent autopsies. 25% of them did have Alzheimer's pathology at time of dissection. So how do we differentiate these two entities? This is a paper which was recently published from Spain, and they had an antemortem working diagnosis for these patients, and they had lumped them under behavioral variant of FTD, and then they tried to compare what was the autopsy findings, whether it was Alzheimer's or tauopathy or BVFTD, and then they tried to see what were the clinical phenotypes. So they came up in their conclusion that, referencing back to the Wizard of Oz, the yellow brick road to diagnosing these disorders may be served by the metaphor of frontal variant AD as the irritable, paranoid, and tremulous scarecrow, and the BVFTD being the heartless, ritualistic, and rigid tin man. So knowing these kind of changes where you are more compulsive or you are more rigid in your thoughts, more apathic, goes more towards a BVFTD variant, versus if you are more tremulous, you have some kind of extrapyramidal symptoms, you are more irritable, you are more paranoid and suspicious, the underlying pathology could be more of an Alzheimer's disease pathology. So moving on to case number 2. So I'm wrapping up the Alzheimer's disease section here. Moving on to the next part. Yes. Sure, so I'm happy to do that. Yes. For sure.
My question is, very often we get early onset presentation in the form of psychiatric symptoms only.
Yes.
There's no cognitive symptoms.
Hello.
And very often, as we treat the person for a primary psychiatric disorder, on follow-up
Yeah.
we find that he's becoming dementic.
Yes, that's right.
In the initial phase, besides psychometric testing or neuroradiological analysis, is there anything else by which we determine A, the cause, and 2, do these patients poorly respond to psychiatric treatment?
Excellent question, thank you, sir. So one of the first things I learned, and my apologies I have not added that in the slide here, is the new term called as mild behavioral impairment. So that term was coined by Dr. Zainur Ismail, one of my mentors back at Calgary. And he was a psychiatrist by training, and he noted the same things that you have noted in your practice, that a lot of patients initially start with behavioral symptoms. The disease process that's brewing has trained us typically to think of only cognition and memory as being the first seminal symptom which comes. But that may not be the case. They can start off with having depression, anxiety, or apathy, which sets in, which later on evolves to involve cognition and then be labeled as an Alzheimer's phenotype. So that term has been coined as mild behavioral impairment. To answer the question, how do you screen for it? So there's a behavioral impairment checklist which is available for free online. So if we were to start using that in our clinics, there is a cutoff score of 8. So if the scores are more than 8, that there is a 30% chance that that person who has only behavioral symptoms may progress on to have dementia in the future. Another caveats there are the behavioral symptoms have to be later in life and new emergent. So later in life meaning person presents more than 50 years of age, and they have to be persistent. That means lasting for more than 6 months. and noted by a caregiver as well. So it's not just the person endorsing changes, but a caregiver also notices that there are changes in the person's behavior. That would be termed as mild behavioral impairment. In terms of response to medications, that's a little difficult thing to answer, because if you go to the literature, there are comments which say that if suppose a person has depression and you treat the underlying depression, they possibly might reduce their progression to dementia, but if it's driven by a neurodegenerative process, that won't stop the process. So the only drug so far which seems to have a benefit on cognition as well as helping out with depression would be vortioxetine. So vortioxetine is acting on different mechanisms, and in mice models has been shown to increase hippocampal plasticity as well. So the best drug in a cognitively suspicious setting would be vortioxetine and escitalopram. So I hope that answers your question, sir. Yeah. Yes, please.
Hi. In your case presentation and also the explanation later, you have been using a lot of short forms. So people who are maybe a bit challenged like me find it a bit more difficult. And also you've also used a lot of terminologies of tauopathy and alpha sign. Oh, I mean, it would be great if you could first explain what it is and then, talk about it.
Excellent. Thank you for the feedback. I apologize for that. So I'll take this as a very important feedback. This is the first time I'm giving a talk, and I'll appreciate that feedback, and I'll inculcate in my future talks as well, and I'll make sure that I don't use short forms. Thank you for that feedback, ma'am. So moving on to the next case, Mr. R, a 65-year-old retired banker with long-standing hypertension, type 2 diabetes, dyslipidemia, and a 30-pack-year smoking history, presents with progressive cognitive decline. So in this one sentence, I have tried to throw in as many vascular risk factors as possible. So he does have long-standing hypertension, diabetes, dyslipidemia, and the smoking history. His wife reports 2 distinct episodes of abrupt deterioration over the past 3 years, each following a minor stroke. So there is a history of 2 change in neurological or cognitive baselines. And between these events, his cognition remains stable. So in these 2 sentences, we can see that there's a step ladder pattern, which would be classically seen in this disorder. And he has poor attention, slowed information processing, and difficulty planning daily tasks. So the frontal subcortical circuits are the main circuits which help plan our activities, which help direct our attention, and they also are involved in processing information. So this kind of a phenotype, when you see lumped together, the suspicion that should be highest should be a vascular cognitive impairment. He also complains of unsteady gait and urinary urgency. Again, higher level subcortical symptoms. And on neuropsych testing in these patients, there would be executive dysfunction, which will be seen as trail making being a little delayed or inability to complete it. There would be bradyphrenia. So if you time them, they will take a lot of time to complete the same task. So for example, completing this clock drawing, compared to normal people, they may take twice or thrice the amount of time that they do. There will be increased primacy to recency proportion. So what that means is, in this word list that we have here, they will tend to remember the first few words and not remember the last few words, which is directly in contrast to that of Alzheimer's, where they tend to remember the last few words and not the first few words. Then working memory impairments, like impaired digit span forward and backwards. So in the MOCA, we have this digit span test that we do. We ask them to repeat a 5-digit number forwards and a 3-digit number backwards. So this would be impaired in a setting of vascular cognitive impairment. Attentional deficits would be there. Attentional deficit is assessed on the MOCA by looking at their ability to tap on serial A's. So that would also be impaired. There would be impaired delayed recall, but may show improvements with queuing. So in the delayed recall part of the MOCA, here they may have impaired memory, so they may score a total of 0 out of 5. But if you give them category cues and you give them some hints to come to the diagnosed answer, they would be able to come up with the answer. So that would be very different from that of an Alzheimer's pattern of cognitive impairment. Then set shifting difficulties. So trail B, where you ask them to connect a number to a letter, a number to a letter, that kind of set shifting ability would also be declined in a vascular cognitive impairment setting. And impaired Luria test. So Luria test could be ability to do motor Luria or drawing a triangle, a square, triangle, 2 squares, that kind of a pattern might be impaired. And the term used to cover this kind of cognitive neurodegenerative process would be called as vascular cognitive impairment and dementia. I tend to use the word same. I replace C with vascular contributions to cognitive impairment and dementia. And the spectrum can be twofold. One, this kind of cognitive impairment could be driven by strategic infarcts. In this case, it's in the left thalamus. Or it could be driven by accumulation of multiple white matter hyperintensities or subcortical changes in the brain. So both these phenomenon can present as vascular cognitive impairments. So the first scenario, how do you give a diagnosis of VCID? So in scenario 1, the onset is temporally related to a cerebrovascular event. It can be either an abrupt stepwise fluctuating course, or it could be step ladder pattern. And it should be persistent for more than 3 months, the cognitive impairments. And there should be an evidence of stroke. So there should be a documented stroke history or some focal neurological signs on examination like a hemiparesis or an extensor plantar or some pseudobulbar features. And in the other scenario, there may be no stroke history, but they still have a subcortical ischemic pattern on MRI, and they decline in processing speed, attention, and executive functions. And plus, there may be more than one of the following: early gait disturbance, early urinary urgency frequency, and change in personality or mood. So generally, apathy is a very common symptom in vascular cognitive impairment. There can also be depression and emotional incontinence, emotional lability that we talk about. So these two case scenarios are the ones where we can suspect vascular cognitive impairment. And on imaging, you can have more than 2 large vessel infarcts, or you can have single strategic infarcts which can explain the cognitive changes. There can be 2 or more lacunes, and if there are 1 or 2 strategic lacunes, then there should be accompanying white matter lesions as well. There should be extensive confluent white matter hyperintensity changes like Fazekas 2 or 3, and strategic or multiple intracerebral hemorrhages like the GRE blooming that we might see in vascular changes. And there can be any combinations as above. The exclusion criteria is none of the following should be there. You should rule out Alzheimer's phenotype, a DLB phenotype, or a BVFTD phenotype, and nothing on the brain imaging other than the strategic strokes or the white matter changes should be able to explain the cognitive impairment. Only in that scenario can we label that person as having vascular cognitive impairment. So why is this important? This is important because most of the research trials have been around Alzheimer's disease and have not taken into consideration VCID. And what is most common in the clinical scenario is a combination of both. So in reality, we don't see pure Alzheimer's as much as we see a mixed combination of AD and VCID. The problem is there's no ICD code for a diagnosis of mixed dementia, and there's no international consensus for diagnosing a mixed vascular and Alzheimer's disease here. So when it comes to giving these medications, it's going to be a challenge, because how do you pigeonhole a person as having just Alzheimer's disease and not having any vascular component driving these changes as well? So clinically, the diagnosis should identify the dominant pathology. If the person has an ancillary event like a stroke which has tipped them over into changes in their personality and thinking, then it could go more in favor of vascular more than AD pathology, or a combination of vascular first and then AD. Or if episodic memory loss is the first step that has happened, followed by a stepwise subcortical deterioration, then you can say mixed AD and vascular pathology. So it's just a change in the positioning, which one comes first. So that was the part about vascular dementia and a mixed pathology. Moving on to case number 3. I think I'll take questions after case number 3. Mr. D, a 72-year-old retired engineer with hypertension and diabetes, presents with a 1-year history of gradually worsening gait imbalance, urinary urgency, and mild forgetfulness. So these 3 symptoms, gait imbalance, urinary urgency, and mild forgetfulness, can be termed as Hakim's triad, these 3 symptoms. And his wife reports he takes small hesitant steps and struggles to initiate walking, though upper limb coordination remains intact. So it's predominantly a lower limb related some symptoms which we would call as vascular Parkinsonism. And cognitively, he shows slowed thinking and reduced attention, but relatively preserved episodic memory. So there is bradyphrenia, there is reduced thinking ability, and there is reduced attention as well, but episodic memory is preserved. So what it means is this person is able to encode their memories, but takes time in retrieving them. So that is what is in essence going on. And he often needs prompting to begin routine tasks and seems indifferent to his surroundings. So this might tell you that there might be some apathy at play at a behavioral level in him. So what is this? So this is something called as normal pressure hydrocephalus, and what you're seeing here is a very narrow callosal angle, and we can see that the pressures in the sylvian fissure are much more than the pressures above. So this is called as DESH, or disproportionately enlarged subarachnoid spaces and hydrocephalus. So in essence, what this is doing is it's eroding your subcortical structures while keeping the cortex intact. And the hippocampus here are also intact, and hence episodic memory is normal, but the bradyphrenia or the thinking ability has slowed down. There are gait issues and there are urinary incontinence issues. So on neuropsych testing for them, they do have a dysexecutive syndrome, something similar to the vascular cognitive impairment findings that I talked about. Their attention speed, the attention and cognitive speed has declined, which is reflected in trail making aid delays. And they have executive impairments as well. On the frontal assessment battery, this is the one which has more sensitivity for picking up subcortical dysfunction, and the scores typically are less than 12. And the most important part is the motor component, like the fist edge palm, because if you were to do a diagnostic lumbar tap and you were to drain a large amount of fluid and you see a positive response and you were to shunt them eventually, then the first thing that can be shown to improve on the cognitive testing front is the motor component of fist edge palm on the frontal assessment battery. So so this is a paper which was recently published in 2025. Gait and frontal lobe function become associated with patients with idiopathic normal pressure hydrocephalus after shunt surgery. So what they quote is that the FAB total score, the frontal assessment battery, analyzed as a continuous data became significant at 6 months post-operatively. So generally, the cognitive symptoms don't improve as much as, say, the gait improvement and the urinary incontinence improvement post doing a lumboperitoneal shunt, but they have shown that cognition does improve, and it's the FAB score which is the most sensitive to improve. MMSC also does improve, but not as significantly. So the therapy here is high volume CSF tap, lumboperitoneal shunt surgeries. Motor improvement is much more than urinary incontinence improvement than cognitive improvement. And we should not forget that clinical correlates of obstructive sleep apnea and NPH is very strong. And again, the fluid dynamics do change with whatever underlying mechanisms might be driving the normal pressure hydrocephalus, and addressing the obstructive sleep apnea might be one way to mitigate the progression as well as to solve the underlying issue. So I think we'll take a break here to answer some questions. Yeah. Yeah. Yes, sir.
Is there any other entity like a normal cortical atrophy? Very often when we take up the matter with our neurologist colleagues, they say that this is age-related, not significant. So what is actually significant atrophy versus non-significant atrophy radiologically?
Excellent question, sir. So, yes, sure, I'm happy. I'm happy. Yeah. 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 Sure, ma'am.
Forget the importance of ventricular volume and just the extracellular compartment in imaging. We've neglected it for a long time. With automated processing now, we can actually compartmentalize ventricle, extraventricular CSF spaces, subarachnoid CSF. There's a relationship between vascular disease and CSF or water volume in the brain. And I think that's something that, I don't know, maybe Joy can address this or give us some idea, because I often find it difficult to differentiate ex vacuo ventricular dilatation from a communicating hydrocephalus, and what is the tipping point. We keep talking about incipient normal pressure hydrocephalus. So there's a tipping point when big ventricles become normal pressure hydrocephalus, right?
Yes, ma'am.
So we still haven't had a handle on, we don't have imaging techniques except for radionuclear techniques, which have just shown the slowing of the CSF clearance.
Yeah, so it's a peculiar thing. Aditya's been around for a few years, I've been around for longer, and our understanding changes the more patients we see. So what we were told about, I mean, we were all taught about normal pressure hydrocephalus because of Hakim's description as the triad of people who shuffle, are slightly off in their personality and behavior, and they are incontinent. And this was the entity, I think, way back in 1963.
Yeah.
Right, Hakim's description of 1963, so the year I was born. And so it got deeply entrenched in historical folklore of neurology. But nobody's asking the question as to why do some individuals develop dilated ventricles and hence reflect the symptoms that these dilated ventricles produce. And you saw those two slides that Aditya showed you where a few years ago, I think 2018, in Baylor College, there's a neurologist called Gustavo Roman, a very feted researcher who demonstrated in 31 patients, 31 consecutive patients who had the clinical syndrome of NPH, and they decided to do polysomnography, take a sleep history, and assess them. And out of those 31, 29 had moderate to severe sleep apnea. So this was the first time that in 2018 a paper came out saying that patients who have NPH should be screened for sleep apnea. So the Koreans and the Japanese got into the act, and the Chinese later, from 2018 to now. And I got into the act around that time. So we screen everybody who has cognitive impairment for sleep. And to quite a horror, almost all these patients who have NPH, and I have 9 of them now, have undetected, untreated sleep apnea in the background. So I asked a question to myself that what's going on here? So it appears that the CSF dynamics of production and absorption is determined by a sleep process, including rhythmicity of circadian rhythms. So there's a huge number of data that seems to suggest that if there is circadian misalignment, it destabilizes the balance between production and absorption. And the other thing which destabilizes this is sleep disordered breathing. So if you have a sleep apnea which is moderate or severe, that in some people, not only does it impair the glymphatic system, which drains the interstitium of these protein products like TDP, 43, amyloid and tau, but it also destabilizes CSF absorption. So we are just beginning to learn that these physiological dynamics, which we considered as a static construct, are not static, they are dynamic, which means they change every day with the things that we do every day, how we eat, how we drink, how we think, how we move, how we breathe, and how we sleep. Now that's something to think about. Of course, we don't have good correlations with diet, but I'm sure that that will come over time. What is very clear is that somebody asked that question about normal atrophy. So the brain tissue and neural networks can shrink and grow dynamically over the things that we do every day. How can we derive that? I think there are studies which show that the hippocampal volumes of the taxi drivers in London who don't use Google Maps had very robust volumes because it is their tradition that a black cab driver knows the A to Z in London in his head. So his geographic skills are very good. Whereas the minicab drivers who have come from Pakistan, the Caribbean, they didn't have those same volumes in the hippocampi. This was a study done in Queen Square. So which showed that learning can improve volumes. The other thing is engagement. So we will come to that in the end. So we, by and large, our brains thrive amongst other things on engagement. You also saw in Aditya's lovely slide that hearing loss and visual impairment is a anvil for destabilizing cognition. So why is that? Because I think the brain thrives on every possible engagement. Visual, olfactory, all sensory, all our senses. So our 5 senses are the ones we use to engage with the world. And if our engagement is impeded somehow, this engagement drops. I strongly believe, and all of you are very senior psychiatrists in the audience, you would probably have observed, like I have, that every dementia patient we see, if you ask them a simple question that, "Ma, what do you do every day?" or "Sir, what do you do every day?" And most of them will say that I do nothing. And we have one in the hospital just now. So when you ask them, why do you do nothing? He says, nothing to do. Because these senior people have something that I don't have a term for it, so I call it engagement holocaust. That somewhere in their lives, their opportunities for engagement was taken away. You and I are singularly blessed. We can continue to go to the clinic and see patients, and some patients will still come, even if you're 85, right? But a person who's been forcefully retired at 60 because of a government regulation, then has nothing to do. And he's got 16 hours of wakefulness with no engagement. So a lot of dementia, and I'm sure Aditya will somewhere in his talk to you about it. So Patricia Boyle in Chicago talks about the importance of purpose. So how does that engagement also change these things? We don't really know, but I'm sure there is some influence. We have learned that sleep biology and restorative sleep, so 7 to 8 hours without any imposition by a sleep disorder, and good circadian rhythms, and that good circadian rhythm is equally important. That means sleeping around 10:30, 11, waking up 6:37. How many of you in the audience do that? Very few, because we have not been taught this, right? And that's also a problem. So they are likely to be regenerative. So a lot of our cerebral volumes, in some people, I know of my colleagues who are 82 years old, and I've seen their MRI scans, and they are robust. There's not a speck of white matter. I can't give you a name, but I know someone who taught me. Not a speck of white matter, and fantastic volumes. So we often ask this question that what's happening there? It's also the way we live, plus these other things. So sedentariness is a problem. Not doing physical activity across life is a problem. So the guys who have not thought about this, after today, go back and find at least some time, and we'll talk about that in prevention again.
Sure.
But sleep matters, movement matters, engagement matters. And you'll tell us a bit more about Lewy body disease now, right?
Yes, synuclein.
Yeah, so we'll now move from here to synuclein. I think Dr. Cholera has got a question.
In the same context, we used to have this old age concept of EPR. Is it still relevant, particularly in the
Whole context of?
ventricular brain ratio?
Yes. So Mayor, you want to take that?
That was exactly my question.
So that is the disproportionate volume increase,
This
na?
whole concept is now changing because it's a dynamic process. What we're even assessing now are biomarkers for the integrity of the white matter around the ventricles. So it seems like the elasticity of the white matter, the integrity of the white
Yes.
matter is a really important factor as well. Because once the integrity goes of the white matter, the ventricles balloon out, and no matter what you do, it doesn't change the process.
So this is all related. So very interestingly, we now know that the blood-brain barrier around the ependyma is susceptible to permeation by two things. There are two products which are called matrix metalloproteinases, 2 and 9. So there are 9 of them, but 2 and 9 are the ones which are relevant. So they did an experiment. They took serum from patients who have sleep apnea, and they put it into mice, and it broke the blood-brain barrier. And they took age-matched controls, and it didn't happen. So then they studied MMP2 and 9, and the MMP2 and 9 levels are very high in people with sleep apnea. So we are learning that in many nuances, sleep is your very big restorer, just like nutrition and exercise. So in our wellness paradigms, we have been talking about mindfulness, exercise, and nutrition, but we have neglected sleep for a very long time. And that's going to come. So the future is going to be integrating all of these things. Would you agree?
Yes, sir, absolutely. Thank you.
Great. Let's show us